lately. But we're just going to go over some general stuff. Trying to up our overall trauma game and approaches. One thing that you'll realize about trauma is the way we teach it is wrong. They always teach trauma as very simple. They're always like, oh, it's trauma. What do we do? What do we do in trauma?
A, B, C, D.
A, B, C, D. We plug the holes, right? We air goes in and out, right? All of these very simplistic things. Yes, that's true. In just like everything in medicine can be reduced, but that's not the whole picture, right? And we can do more with the scopes that we have to hopefully give our patients a better shot, because we don't live 20 minutes from a trauma center. We can't just stick our finger in the hole, no joke, as Dr. Peters told us to do, finger into hole and hold it. We have to do a little bit better than that. We are a long ways out. There's a great podcast on this if you guys are nerding. The Prolonged Field Care podcast is all about military type medicine, austere conditions. I would say in some ways it's closer to what EMS does than even like some of the crazy ICU ones.
What's the name again?
The Prolonged Field Care podcast. I like it. I do skip through a lot of them. I don't listen to every single one of them, but some of them are really good. You'll be a lot less afraid of needle or surgical cracking after listening to that one, because they'll just walk up to be like, oh, you might need an airway in the next 24 hours. Bang.
Yeah.
So anyway, one thing that they do bring up a lot in that podcast, and I think it's super fair for us, trauma needs to be also approached with some humility. We are trained to go rush it. Trauma is like our marketing tool for EMT basics, right? We're like, go get the guts and glory. You'll be on the front page of the newspaper, and you'll drop them off into a helicopter and all this stuff, and then you take dialysis transfers for your first year, right? Like, so it does. It gets taken to a place where it probably shouldn't. And it also kind of implies that we just inherently will know what to do on all of these traumas. So I sent Mikey the study on situational awareness. Did you guys get that?
I haven't.
We'll send it out after this. So they did a study, and it's not perfect, right? Because there's no real perfect way to do this, but it had to do with like virtual reality and stuff like that. But they wanted to see how EMS teams did when they were on some of these calls and how to rank their situational awareness. What do you think happened?
Tunnel vision across the board.
We were not that good.
Yeah.
There was a lot of tunnel vision. There was a lot of closing down. There was a lot of
Well, I was watching a video once where like they had like a bunch of these people like doing some sort of elaborate dance, and going in the video like they ask you like, you know, what
is this the gorilla?
Yeah. So what was the person in the blue pants doing? What was the person in the red pants doing? And the whole time you're focused on these guys so much that a gorilla crosses the entire screen, and no one has ever seen the gorilla. It's like, yeah, well, it fell down.
You don't see it, and so with that. One thing that I would say is that if you can stay as a team in these trauma scenarios, and this is kind of getting off of like the meat and potatoes, but let's start with big picture stuff, right? When we get to some of these traumas, let's just take an MVC for example. We get to a trauma, make sure there's at least one person out of the two that's looking at the big picture. Everything else. Because when you start doing patient care, it's easy to tunnel into that patient. And that's fine, as long as you have the bases covered as a team, right? This is why so many people die when their spouse dies, is because they kind of actually share a brain. They split responsibilities, okay? So when you're going out there, it's worth denoting one person like, okay, you're going here, and I'll look at like everything else, right? This is what happened on our MCI. I took that role of looking at the big picture. This is where I want the helicopters to land. This is where I want all the trauma patients to go. This is who I want called. And we need to make sure that no other vehicles drive through that scene, which
Like
they did. And we couldn't stop them. Even me trying to stop them, they drove right by me. Trying to protect everybody, because at the end of the day, we all want to walk away from these. We do. And no matter how sick that trauma patient is, they got themselves into that situation. We're trying to help them out of it, okay? We need to go first. In wilderness medicine, you are the first person to be saved. You are. Don't give everything to that patient, including your life, okay? So make sure scene safety. I know what is it like? We got our BSI scene. Is our scene safe? And they're like, yes, it magically is. Scenes are never safe. I don't know where this theory comes from when they're like, oh yeah, scenes are safe. Scenes are always either risky or less risky. There is always a risk, right?
What would happen if during a skill scenario the proctor said, no, it's not?
Yeah, the scene has become unsafe. You're like, we didn't practice this. They're like running with their gloves. Where's the cops? I mean, it's true though. How long did we wait for NHP? The helicopters were leaving.
I waited for
Yeah, no, we were. And NHP passes us as we're driving back to town.
Yeah.
Minutes before NHP came.
At least 45.
Yeah.
An hour.
It's
We
forever.
were out there with this guy.
It's forever. Like it is crazy how long it takes to properly secure a scene. And are we now real life? We always say what? Well, if the scene's not secure, what? They don't go in, right?
Yeah, that's a thing.
True or not true?
Pass
True.
that test
I
too,
went
just
in.
like everybody, you know?
If we were taking the EMT test, it's
Yeah.
true.
It's absolutely true. 100%. You pass.
Yeah, I literally turned around, found somebody who was wearing a helmet, and said, "Get in the back and hold C-spine." that was my complete induction into safety for that scene.
Yeah. One of the earlier traumas that I ever ran, it was just a guy. He was in an MBA, not pretty low level, but this was back in the day where we C-spined and backboarded everybody, which we'll go over why we don't do that anymore. But we C-spined, backboarded him. And as I'm pulling him into the ambulance, his gun falls out of his pocket and lands facing me.
Oh, wow.
See, not safe.
Yeah.
Suddenly, finding drugs on a patient happens too, right? Like, scenes are dynamic. And so, one trick that I have in my head is if you're watching a blood pressure cuff, if it goes off Q15, at Q15, stop. Whatever you're doing, mentally stop. And then is the scene safe? And if I had this patient right now, just started, would I be continuing what I'm doing? Okay, stop. What we're doing the right direction? Yeah, keep going. But then 15, 20 minutes, 30 minutes, however you want to do it. It's really easy on our fixed wing transfers because there's so many breaks in the action. When I do helicopter transfers, this is when I cross a town because it's Nevada. Like, there's not many of them.
Yeah.
So we'll fly and then it's like, oh, Wendover. Okay, boink. If I just had this patient right, A, is what we're doing intelligent with this helicopter? And B, if I would just get this patient right now, would I keep doing the same thing? Or should I think about doing something else? And a lot of times the answer is yes, right? But 2 or 3 times I've been like, maybe not. Maybe I would think about doing something different. So anyway, have somebody watching the big picture if you can. And if that needs to be like Mikey, if it needs to be someone not attached to patient care at all, a cop, that's fine. Just make sure that somebody is stopping and making sure that we all get to go home. Okay? Big. Okay, so one of the most, I would say, out of Lander County, probably the most common thing trauma-wise that you guys are going to run our MBAs, right? You've got a super high-speed highway that goes south out of here. You've got I-80, which people go 80 on I-80, right?
Yeah, everything, it's a sheet of ice they do.
Everything is fast.
Yep.
You've got speed in all directions, right? So one thing I want to just very briefly today talk about extrication. In my time, the thing I've noticed the most about extrication, the one mistake I see again and again and again and again and again is tunnel vision. You go, the patient's sitting here and there's a door right here. I need this door off. And sometimes you do. A lot of times, cars have more than one door. I would say the majority of cars have more than one door, right? And it is shocking how often me, get tunneled into, I need this door off. And I walk around to the other side and literally open the door or break a window and go right in, right? So remember, this is that trying not to get tunneled down into an algorithmic type thinking and being able to stop and look at the big picture again, right? Parking brakes are a big deal, stuff like that. So with your extrication, and also don't forget, like if you're extricating for a long time, treat your patient in that vehicle. Like patient care for us doesn't start when the patient gets into an ambulance. We got to start it in that vehicle, right? And so that might mean, sending someone in. It might mean getting an arm to the outside where you can at least start some medication, some vital signs, stuff like that. Because what do we really need to start as an arm? We need like an IV, we need a blood pressure, we can start to get like some SpO2, we can start to get maybe some quick like pulse ox on them, and we can really start looking at our patient with an arm. Okay, so that's pretty important. Sound good?
Yes, sir.
Okay. Also, extrication tools. Let's talk about extrication tools. Are extrication tools fun?
No.
Yes. Hell yes, they're fun. What are you talking about? They're super fun. Popping doors, cutting locks, They're super fun. Just remember that may or may not be for everybody. We don't all need to be on extrication at the same time. Someone needs to be watching that patient, okay? Or multiple patients, however it breaks out, okay? Extrication is something that a lot of people can help with, but patient care is not. That's our job, right? Don't forget your jobs, right? Last thing, backboards. Let's talk about backboards while we're on it. What are backboards good for?
Mannequins.
Mannequins. They are good for mannequins. Surfing, I would imagine so too. I've never surfed on a backboard, but as long as it can plane. What is it really good for us?
Moving patients.
Mm-hmm.
Moving them.
Moving them. That is when it's good. Sometimes you just have to physically get a patient from a place to a place.
And that's the way it is.
Scoop stretchers, backboards, kind of all sort of fall into the same thing. Mega movers, all sort of fall into the same thing. Why don't we use backboards anymore?
They hurt the patient.
They do.
Yeah, it can cause resistance to airway up to 15%. It causes ulcers for the people with poor circulation, which is everybody in a wreck.
Yep.
And
They're hard to shove into helicopters.
yeah, and the length of them makes them awkward to work with.
So there's been a lot of studies on backboards. The one I like to reference quite a bit is they took a team out of LA County that was their extrication team. This is the car cutting team. This is what they do, right? I'll usually refer to as like a heavy rescue unit, right? All they do all day long is they train on that and hazmat. That's what they do. And so this team, who is way better than me or you or you or you or you, they're better than all of us at this, okay? So they got this, they put a patient, this is Hollywood, they put him in that motion suit, right? That senses motion, that makes you be able to play Gollum in the movies or whatever. So they put them in a vehicle, and they had them sit down, boom, into that vehicle. And then they said, okay, we're gonna have this team extricate this patient and put them onto a gurney, okay? So they tried different methods. They tried a rapid extrication, where you guys remember what the rapid is. You put the board underneath their butt, they slide their feet over it, and then you pull them down onto the board, basically. Essentially, you can do it facing the car or outside facing. Depends on the situation. So they tried both of those, and then they did C-collar, where they helped them out. They did all sorts of stuff, right? What they found overwhelmingly was that when the patient had the least amount of spinal movement is when they said, don't move your spine, walk to that gurney and sit down.
Really? Wow.
Yep. And it makes sense, right? Because how many of you guys have ever backboarded someone out of a vehicle? How much movement does it take?
Oh, a ton.
Oh,
Terrible.
A ton
Jarring.
of movement. It is like, I don't care if you are working with your homies and you've been doing it for
Oh,
years.
dude.
You move that patient so much doing that. And when we get to where we want to go, generally speaking, these patients a lot of times are conscious still, right? Because if they're unconscious, you're probably about to die. So these patients are conscious, then we get them onto the gurney, and then what? They lay flat. What's the problem with that? Like CJ was hinting at.
It's like laying on the ground
Yeah.
camping.
Yeah.
I mean, there's no padding.
Yeah. Does anyone sleep like that?
No.
No. Like, you at least put a pillow behind your head.
Even dogs curl up.
Right, right. No, this is not a natural human position. And then we're like, so, sorry that you're hurt. Now go into this really bad position and stay there for hours.
Plus, I've actually done my own little research, and that's why I use the Mega Mover on the stretcher with the fast splint. Because I counted 7 times, minimum, 7 times. By the time we get them out on the gurney, get to the ER, and then we move them on the bed, and then we go to radiology, on, off, we go to CT, on, off. Minimum 7 times a patient is moved.
How many, and I've got another one for you that you reminded me. How many of you guys have had someone throwing up in your ambulance before? None? None of you? No? Oh, okay.
A
Couple of you? Couple of you had someone throw up in your ambulance? I've had a couple, like hundreds. So what happens if they're sitting up? What happens? All comes out and it all goes over their chest. What happens if they're on a backboard?
It's the fountain of doom.
Oh.
Yeah.
Then what do we do immediately?
Run away.
We roll them.
Yeah. More movement. Yeah.
What happened to our C-spine restriction? Terrible. Went to 0 right there.
We just really tested the tensile strength of duct tape.
Yep.
Yeah.
The last study that I'll reference, and I don't have this one written down, it was out of Indonesia. And Indonesia has, from what I understand, like 2 different, I think they have 2 EMS systems. There's like a private one that has ambulances and paramedics and stuff like that. And then there's one that's like rickshaws and like they get people to hospitals.
Shamans and
witch
doctors.
And so
It's Uber Med.
yeah. This is the okay. I don't want. I was gonna make an AMR joke, but I'm not going to.
Yeah.
We all know where we're going with this. So anyway, they compared the rates of spinal injuries between the 2. Now and this was over like years. So roughly they ran the amount of accidents the same, right? You run enough of these, you're gonna have enough cervical injuries, blah, blah, blah. So they compared the rates of the 2, and guess what the difference was?
Nada.
Really?
Not one.
Rickshaw versus ambulance.
Nothing.
Oh my goodness.
Yep. So we are probably a more spirited debate is going to be collars. But when it comes to backboards, they're pretty much out. Okay? Like most of our trauma patients should not be backboarded. The big vacuum splint, I could see the benefit in it. Just make sure that your patient can like sit up if they need to and throw up. That's the big one for me. Aspiration pneumonia is crazy how that changes the dynamic of a trauma. Okay, Mike Cooper, by the way, he might call in today and do a little talk. Mike and I were on a patient not too long ago. He aspirated, and the ventilator settings on him were the same as I would use for an ARDS patient.
Oh really? Wow.
Yeah, it was horrible.
He aspirated.
Because he aspirated. They said he was working with the capacity of 1 lung.
Not only that, but it burns the throat and ruins the vocal cords.
Oh, it's terrible. Hard collar versus soft collar.
Well, let me just touch something real quick. Our
Oh, go ahead.
protocol right now says selective spinal restriction, right? Selective motion restriction.
Yep.
Our protocol says we do not backboard anybody unless we're trying to keep them in one piece together.
Yeah.
So unless that is the case, you do not backboard people.
Very low likelihood.
Yes.
And even then, I would say err on the side of vacuum splints.
Yeah.
Like the full body vacuum splints are a really, really exceptional tool for that comparatively.
Mhm.
A lot less pressure ulcers. They form to the body. It's a little. If you've ever laid in one, they're actually not horrifically uncomfortable. The backboards. Anyone who went through EMT basic and was like, "I'll be that guy,"
Yep.
or they lift you and twist you and do all of that stuff, they're pretty uncomfortable. Okay. So if you have to do stuff like that too, remember pain control on your patients. Don't be that guy. Hard collar versus soft collar. So Med-X, we've switched to soft collars. These are literally just like a collar that comes around here. A couple different theories.
Is it the ones you see in the movies? That they're always like, oh, I was in an accident 4 weeks ago and I still have to wear this thing.
Kind of. They're probably even less than that, right? They're like literally like a band of foamy thing that comes around, and it says like on the front, it says like patient hasn't been cleared, right?
Like that football collar.
Yeah. A lot like that bread roll type collar. So there's a couple different thoughts on this. One, especially in head injuries, what those hard collars prevent venous drainage. Okay, so it actually holds ICP up into the head, and that's anytime we close off a vein for hours, it's probably not great, right? So that's one argument. Another one is that they're not doing much good, and they're horrifically uncomfortable for your patient, making it probably a little bit harder for them to breathe, and hypoxia is a known killer of trauma patients. We were just in a trauma review with one of the big trauma docs out of IMC, Dr. Long, and he said that hard collars still with all the neurosurgeons are kind of the standard of care.
But the tool, they're not the prevention.
Yeah. So anytime, like let's say you go to IMC and you fell off a ladder and then you go in and they scan you and you have a C2 fracture or something like that, they are going to put you in a hard collar for like 4 to 6 weeks. The debate will rage on. It will all depend probably on what Dr. Herman wants. Hard collars you'll probably see them stick around because the neurosurgeons like them. And that's where I see that going. There are some people like Dr. Hudson who are against them.
I have heard of possibly a new toy coming out that's supposed to be like a vacuum splint for the neck.
Oh, that'd be sweet.
Yeah.
That was in Prodigy.
Yeah, that'd be sweet. That'd be
I'm
great.
not sure where that is in the production line, but it's something to look forward to in the future.
How do you get my big thing about a hard collar is every single time I've had to manage a trauma airway, I've had to take that collar.
Oh yeah, 100%.
Every single time.
100%.
So
100% failed with that. You also won't, even with hard collars, when you take those off, the manipulation of like an ET blade or a positioning is probably not going to cause more trauma to that airway. That was Dr. Reach's medical control. I can't remember his name, but that was his argument, is that like they did an imaging study where this was under CT, and they took the collar off and they moved it around to manipulate and look at like airway positions and stuff. And that amount of movement between a ramp and a pillow and blah, blah, blah didn't cause any more like probable damage. So absolutely, if you are trying to do airway stuff, get that collar off. I've intubated in one collar, one time, and that will be the only time that I ever attempt that. Yeah, I did it in Fallon and it sucked.
Was it a super rush job? Is that kind of why? Or?
No, it just wasn't in our protocols to take them off.
Oh, really?
Yeah.
So they have to bite the bullet and work through this obnoxion?
Yeah, and it your jaw ability to move is really difficult with those collars on.
Yeah.
I mean, I was like white knuckled flexing, just trying to get a little bit of lift. It's really hard, and that was direct too. So there's another part of that. Hard collars versus soft collars. I don't know. We'll see. Okay. So general traumas. I was thinking about this a lot. And there's some things that pop up on all traumas that we can probably do something about. Remember, we're talking about big traumas here, right? Like, if you have somebody who fell out of their chair and they've got a bruise on their bum, do we need to start the whole trauma protocol, calcium, TXA? Probably not, right? Like, remember, there's a spectrum to traumas, but did that patient fall and actually have a major trauma? That absolutely is possible, especially if they're on thinners. So, how many of you guys are familiar with the diamond? The diamond of, sorry, it's the triad of death right now. The triad of death.
Yep.
Fump. Hypothermia.
Keep thinking about Resident Evil.
Lactic acid
Yep, acidosis.
and coagulation.
That's right, Karen.
Yes, sir, you got it.
Coag. Now, and then we're also going to Dana-ism this too.
So now it's the paper airplane from calcium.
This is the diamond of death. This is the triad of death. We'll stick with the triad for now. I'll throw in my calcium talk. But one thing to remember about this right here is that this is a complex web. This is not one leads to the other leads to the other. One can affect all of them. This goes a little bit to Randall's talk about like the 5 hillbillies. You can't mess with one without messing with all of them, right? Like this is the Battle Mountain Biker Gang or whatever it would be over here. So let's talk this through. All right, let's do a little bit of cause and effect analysis, right? Okay. So how many of your trauma patients are hypothermic in real life?
A lot of them.
A lot of them.
Because they're always an hour on the road before we even get there. Kind
Or
of
they
stuff.
lose so much blood.
Yeah. So why does trauma lead to, why does hypothermia lead to, say, coagulation?
Because you need a certain temperature for your proteins to.
That's right. Yeah. This is clots. This is clotting.
Plus they've lost their oxygen in blood.
Ah.
Which has oxygen, which
Ah.
causes the hypothermia because there's no circulation.
Yes. Yeah. So you've lost blood. You have blood loss. Which leads back this way, right? Blood carries heat. Now we don't got no heat.
Technically, the blood's clotting fine. It's just on the outside of the body.
That's
there
true.
we go.
That's not true. If it's cold,
Oh yeah.
it doesn't clot. A cold blood won't clot as well.
Yeah.
What else? What else with hypothermia would lead to acidosis?
Because you're building up the lactic acid. Because
Yeah.
Once again, you're not circulating, so if you've ever run
So your
really
buffer system's
hard,
being thrown out of
you
whack.
start hitting that wall.
Why?
Because you do not have the oxygenation of the muscles
Yes.
and circulation of
Yes.
the blood in the organ.
Well, so that would be more of a coag, right? Yeah,
When
blood
it comes
loss.
Together.
Yep. This is, remember this, guys? Paramedics, don't run away. A left shift.
Oh, yeah.
Oh, damn it, this thing came back up, didn't it? This is the oxygen disassociation curve, okay? As you shift this to the left on this curve, which this curve generally looks like this, I'm sorry, something like that. As you shift this way, what happens to your 2,3-DPG?
You hit the wall. Your energy.
You guys remember this? This is hard.
Are you talking about like ATP stores?
Nope. Okay, so oxygen goes in, right? Hits that bloodstream, attaches to what?
Hemoglobin.
Hemoglobin. When that hemoglobin wants to go to the cells, what gets released to cleave it off?
Carbon dioxide.
2,3-DPG. So that 2,3-DPG goes in and it cleaves that oxygen off of the hemoglobin so it can hit the cells. Okay? So it's transported where it wants to be, cleaved off. In a left shift dynamic, now all of a sudden that 2,3-DPG can't do its job and it can't pull the oxygen off of those cells as well, so that doesn't go to the cellular
Because of the acidosis or because of the hypothermia?
because of the hypothermia.
Oh, okay.
And I'm sure there's
Write
a
that down, that 2,3-DPG
Yep.
thing?
Is
I think
it
I'm just
also
not- I'm not
the
visualizing it for
CO2
some reason.
buildup, Dave?
Yeah, I'm not either.
okay.
I remember this.
Okay, so let's see. Let's do it this way. More drawing. Let's say this is your cell, right? And this is I don't know, a kidney cell.
Darn kidneys.
I know, we're doing this again.
The last thing you think about during a trauma.
I know.
What do you mean you can't take more fluid?
So this is the heme, right? And this heme has 4 places where it can take oxygen off. This is a red blood cell. That's why I drew it in red, conveniently. Okay, so it's traveling all over here, right? This is 100% SpO2, right? It's full of oxygen. Well, this kidney cell says, I want some of that because we're starting to get a little bit of anaerobic metabolism, right? I need some oxygen. I'm just like everything else in the human body. So it releases 2,3-DPG, and that 2,3-DPG comes up and it cleaves that O2 off so that O2 can go back into this cell. So it will break that off. It was referred to me as a crowbar. It crowbars it off and goes into the cell, okay? Well, what happens when you get cold is this doesn't work as well. And so when it comes up, it may or may not get that oxygen off of that cell. And so you can't now get the oxygen into the cell, which does what to your ATP production?
It encourages more
It turns into crap. You don't get as much energy out of that cell, the cell stops working, you release lactic acidosis, and booyah, we're right back into the trauma triangle, right? Well, that sucks. So that's hypothermia can cause lactic acidosis. What else does hypothermia cause?
Carbon dioxide.
On every patient. Bradycardia.
Oh, shit. Yeah.
I was gonna say denatured proteins, but that's not right.
Brady slows down. What kind of hypoxia happens when we slow the system down? Remember this? It's a stagnant hypoxia. Your blood isn't circulating fast enough in order to get those red blood cells quickly enough up to the lungs.
So the body's conserving itself.
So then we get back to more acidosis. Lovely, sweet.